So this is not about science fiction. This is about what we can do today with handheld devices that are like having a hospital laboratory at your fingertips. And this is something that we can take into the pre-hospital care field right now, and it'll be just as useful to us as the medical tricorder was to Dr. McCoy in the series Star Trek. Now, I did not write the article, What's the Point of Care, that you might have read in the February 2014 issue of EMS World. That was Kevin Callipy and his friends over in Virginia, and I think Kevin did a fantastic job of articulating where point of care testing is right now and what it can do. I'm just going to touch on some of the high points of that, as well as give you some specifics of where getting instant feedback on patients is going to really help us in out-of-hospital care. So to kind of start off with, all hospitals have to have standards. Every laboratory that does medical tests has to fulfill government requirements and accreditation requirements. They have to have daily checks on all the equipment, and they have to make sure that the equipment is calibrated for accuracy as well as proven to have precise readings. And part of that for making sure that these are tests that are reliable. And reliability is measured in two ways. Tests are shown to be specific or sensitive. And the specificity of a lab test is how well it determines or detects something. So if you're looking for a biomarker for a disease and you didn't detect it, and it's a reliable indicator that that person is in fact sick with that disease, then it has a high rate of specificity. So I call it the positive test. Sensitivity. If a person is not sick, you definitely want to know and not treat them as if they were. So the degree to which a test detects that the disease is not present is called the sensitivity, or in other words, the negative test. We're used to using a variety of instruments right now in pre-hospital care that not long ago were strictly laboratory tests. Take, for example, pulse oximetry. For almost 25 years now, this has become a very common fifth vital sign in assessing patients in pre-hospital care. And we have found recently that it definitely has a role in determining what range of oxygenation we need to be giving our patients. Recently, we've also seen that there are pulse oximeters made now that can detect carbon monoxide, which used to be one of the concerns we had with patients who were toxic if they might have had a false positive, that they had a higher O2 saturation than we thought because of carboxyhemoglobin. So now that's out there. And of course, we've been using blood glucose monitors, just like patients have been checking their own glucose for years with devices that have been proven to be pretty accurate most of the time. And we're carrying these in ambulances, and they're an important part of pre-hospital care right now. So if you're used to these, you're used to point of care testing. And now we're going to step it up a little bit. Put a small piece of venous blood into a 1 cc syringe, and a smaller amount of that into a small cassette. This can be pushed into a machine called the iStat, made by Abbott Laboratories. The iStat is a device that gives a wide range of laboratory values, and it's accurate. This device also needs to be calibrated regularly. So agencies and departments that are going to use this should have a user agreement with laboratories. Another device, very similar, is called an Epic blood analyzer. Both of these have the possibility of transmitting their information, storing it and recording it, and downloading it electronically. So it's very easy to put a complete chemistry profile of your patient into an electronic. Now, to get CLIA waiver, that means that you have a device that is generally considered accurate enough that you can use it outside of a hospital environment. And a lot of tests have been granted this CLIA waive status. On this list is the iStat Chem 8 Plus and the iStat 6 Plus cartridge. So these are two cartridges that you can buy that need to be refrigerated. But then you can use for several days after you take them out of the refrigerator, and insert them into an iStat machine. And so now we can use these in an ambulance. So what does the iStat Chem 8 give us? Well, it gives us all the blood gases. So as we're doing ABGs, which we've talked about separately, that, and you know that I believe that paramedics should definitely be comfortable in interpreting blood gases. You can see that this is going to be very useful in the field. At the same time, the same test will give you electrolytes, including ionic calcium. It can also give you the H&H, so give you an idea of that patient's ability to carry oxygen. And as an added plus, it also checks glucose. Now the iStat Chem 6 Plus gives you the glucose and electrolytes, does not give you the blood gases, but it still gives you the H&H, and it adds BUN, so you can get an idea if your patient is maybe having some issues with their kidney function. So where do we go? If we get these evaluations, if we get these test results, we're going to need to learn how to interpret them, and that's got to be part of the training, part of the utilization. However, many people are intimidated by that. After all, there's an awful lot of lab tests that are available in that iStat machine. And just because I'm approved for some, what do I do with the rest of the information? Will it be of use? Well, keep in mind that many things in EMS we start with as a reporting basis. If you don't know how to interpret it, you should at least learn how to report it and report it accurately. You have it, and you can download it electronically. You can transmit it, or you can simply state it. Remember Johnny and Roy and Rampart Base? Well, I realize most of you never watched that, but at the same time, that's our history. This is how we began. We've come a long way from there, and we can make that transition again. I have a friend of mine by the name of Fidel Garcia, who's also an EMS educator, who liked to tell his students that ABGs are like the EMS report card. When you bring your patient in and you want to know how you've done with your job, ABGs will reflect the effectiveness of how well you've been ventilating that patient, oxygenating that patient, and basically giving you a better idea of whether you've met the goals you were trying to meet or not. ABGs can determine whether your problem is respiratory or metabolic, whether the patient is acidotic or alkalotic, and can be very helpful in terms of developing targets that we'd like to achieve in treating our patient. Having that information before they get to the emergency department can direct better emergency department care. But I'll take it one step further. Maybe they can help. Now, when I say that, many people are immediately thinking about the fact that, well, I'm not going to draw a blood gas from an artery. That's beyond my scope of practice, and I've seen people struggle to hit an artery, whether they're respiratory therapists or even physicians in the emergency department. If the patient's sick, it's hard to hit that artery. Well, the fact is you probably are going to be able to start an IV. And if you start an IV, you can get a venous blood sample. A venous blood sample compares very well to an arterial blood gas sample if what you're looking for is pH, PCO2 levels, or bicarbonate levels. And this is where I think that we're going to find a lot of utility in a point of care device. Here's a comparison that was published recently with the results of 480 volunteers who had arterial blood gases and venous blood gases drawn and compared. And it pretty well went with the theory. And that's that the pH compares very closely, often within 0.02 pH. And the PCO2, you can see a linear relationship. Pretty much if you add 6, you'll know what the VBG should be compared to what it should be for an arterial sample. Of course, the PO2 is going to be widely different. It makes sense that it would be around half or less of what you would get with an ABG, but that's not what we're going to be drawing a VBG for. And the bicarb correlates very, very closely. So you do a VBG and it's not looking good. Well, could it be because your patient's PCO2 is way high or they're in severe shock, in which case that VBG is a little less reliable? Drawing it again may improve your information, or better yet, getting an ABG once they arrive in the emergency department. In these severe cases, I think you're going to be treating these patients the best you can with or without that information. So for the most part, I think that's moot. Another thing that we're going to get from point of care testing that I think is pretty promising is being able to determine electrolytes. And I know electrolytes are going to be covered again in another part of this refresher. However, I would like to point out that knowing the patient's sodium level can certainly give you an indication if maybe you've given them too much saline or too much sodium bicarb, especially with the use of hypertonic saline that is still experimented with in the pre-hospital area. This may be very important to note. As well as remember that a low sodium associated with a patient who's going to act very much like a patient in hypovolemic shock. And this can be caused by things like renal problems as well as metabolic shock, vomiting, diarrhea, sweating, and just overall sodium. Another potential is knowing about potassium. Knowing if that potassium is high in its range can give you an indication of renal problems. But more importantly, we see that where potassium goes up is when tissues are damaged. So this is also seen in severe shock states. It's one of those indicators that your patient is in progressive shock and approaching irreversible shock. In fact, with a high enough potassium level, we can also use that as an arrest to determine if a patient is in fact dead and stop resuscitation even when the patient is hypothermic. So this is another reason why I think that's an important value, and one of the reasons why I'm showing you the picture of ice water. So also we know that hyperkalemia and hypokalemia both have profound effects in cardiac function. So knowing the status of potassium in relationship to how your patient is doing with his EKG or the cardiac output can be very useful information as well. For example, in this particular picture, is this a patient in VTAC or a patient with a supraventricular tach with wide complexes? In this case, is it wide complexes caused by a high potassium? Which brings us to the heart. In this country right now, we're very proud of the fact that EMS is making great strides in getting patients quickly to the cath lab, shortening that time that their muscle is deprived of oxygen before definitive care by early detection of myocardial infarctions. Part of this is done by interpreting 12-lead EKGs in the field. Well, that works great, but sometimes the EKGs are not reliable and not very clear. If you can determine a troponin level, troponin is a very good for telling us that there's myocardial injury. It's very specific to the heart. So when you have that myocardium injured, within 10 minutes you're going to see a positive troponin level. Usually this is repeated in the emergency department, and that's important to note too, because when we see a trend in increasing troponin, we also have another indicator of an MI and a need for intervention. Now, it's been proven that these tests can be done in a moving ambulance compared to the emergency department. But prior to that little study being done in Denmark, they were checking pre-hospital troponin levels and proved that it was an effective tool for detecting MIs and getting patients to the cath lab in Denmark. It can help with those EKGs that are difficult to interpret as being positive or not positive. And at least 4% of the patients that have an MI will not have ST segment elevation. So in these cases, troponin is the best way of diagnosing that non-STEMI. The next little test that I'd like to point out that we can do in the pre-hospital arena, which right now is not CLIA waived for use with the iStat, but that's lactate checking. And in fact, there are many lactate testers out there that are kind of floating under the radar of the CLIA waive status. That's because they're used by professional trainers, athletic trainers. If you're preparing to do a marathon or a triathlon, you want to train yourself to the point of going into anaerobic metabolism, and the lactate tester proves that you've accomplished that. Well, anaerobic metabolism is exactly what I don't want for a patient who's in compensated shock. it would tell me he's going into uncompensated shock. And that is where lactate testing can be very useful, because so often that is the thing that we're relying on a vital sign, blood pressure, which is in fact still a late sign of progressive shock. Lactate testing has been proven to be reliable for early indication of uncompensated shock, and is proven effective in determining septic shock. I had the pleasure of listening to a report by Dr. Marie Mullen with Boston, Massachusetts Life Flight program. And they've been testing troponin use in the out-of-hospital area, and particularly have found it useful in determining if a patient is in septic shock. Septic shock is one of those types of shock where the patient goes into multiple organ dysfunction syndrome long before they actually become hypotensive. And septic shock is highly mortal. And one of the problems with it is that we usually detected too late to be treated effectively. With early treatment, we can detect it and treat it much more effectively, and that's where lactate levels can be very useful. In fact, they can also predict the risk of death from almost all states of shock, including cardiogenic shock. At the same time, they give you a target, a goal. So clearing the lactate is a indication of effectiveness of treating for shock, and can be correlated with survival. So there's this fantasy, that we're going to be able to pull out our smartphone, and with it we're going to be able to tell what's going on in our body, what kind of illness we may have, and what kind of care we need, and where we should go to get it. And it kind of comes back to the Dr. McCoy model. This gentleman here has invented something called a Scanadu, a little device that attaches to your smartphone that gives you a few vital signs. And it's done because he visualized that there are many people who, if they just knew more about what was going on in their body, would be able to get early care for illnesses, early information for health problems that they may have. And this kind of opens the door to another idea, a convergence of a few that I think are happening in kind of an exciting time. So point of care testing will become part of EMS care. It'll definitely have a role in emergency medicine, but it already has an important role in preventative medicine. The other aspect of care that is taking place in this country, and that is drawing your attention, is the mobile integrated healthcare concept, or community paramedic. Community paramedics, in fact, in the current curriculum are going to be trained for point of care testing. So there's already this strong overlap. But the more we see both of these, the more we're seeing a higher level of sophistication in our out-of-hospital healthcare delivery. And now if we add to that an informed consumer, people who can give you information about how they've been before, during, and after a visit by a community paramedic or by 911, people who have a better idea of how to take care of themselves after you leave and before you leave, then we've really got a convergence that is going to take us into a much healthier direction for patients of emergency situations, and ultimately better outcomes. And that's what I see is the goal of bringing all this together. And as I look to the future, and I was preparing to do this talk, I kind of tripped upon this little TED talk by a guy by the name of Jack Andreka, who, while in the 6th grade, found a very inexpensive way to detect pancreatic cancer with much, much earlier results than any existing testing. So I would invite you, when you are done with this presentation, to go to this YouTube site and hear a little bit about Jack Andreka. And what he talks about, too, is as he accomplished what he could as a kid because of information available to him through the internet and through Wikipedia and many other sources. There's also a lot of information that is not available to the general public because you have to buy it. And I think that one of the things that we're looking forward to Even as I was putting this presentation and realized that getting those studies that gave me more information, you have to have the right subscriptions and you have to have the right affiliations. If more people had open access to this information, there's more we could share and help each other learn. So I have a little optimism then that maybe in the future, instead of looking at smartphones as a way of keeping us from being connected, that we'll finally be better connected with good information and able to help each other in a wide variety of ways that we have never dreamed possible before.